Small bowel has always been a difficult area to access via endoscopy. Video capsule endoscopy and balloon assisted enteroscopy have their disadvantages. With the advent of novel motorized spiral enteroscope, enteroscopy is less cumbersome, total enteroscopy rates, and time taken for enteroscopy have improved. The novel motorized spiral enteroscope is 168 cm long, 11.3 mm in diameter, with a 3.2 mm working channel. It has a single-use detachable spiral over tube, 24 cm, with soft rubber fins, 18 mm in diameter. This fits 16 cm from the tip of the scope. It has an inbuilt motor operated by a foot pedal, which drives the spiral segment. Forward pedal activation pleats the small bowel and moves the scope forwards. Backward pedal causes unpleating of the bowel. A force gauge indicates the pressure on the spiral segment. If this pressure reaches a maximum, the spiral motor automatically stops. It is indicated in patients requiring deep enteroscopy for diagnosis of small intestinal bleeding, polyps, tumor, or IBD, and for therapeutic enteroscopy for hemostasis or stricture dilatation. It's contraindicated in patients who are not suitable for general anesthesia, those with perforation or uncontrolled coagulopathy, pediatric population. In addition, anterograde approach, foregut stenosis, eosinophilic esophagitis, or varices are contraindication. In retrograde approach, severe colonic inflammation or stricture are contraindication. This is a case series of 14 patients who underwent novel motorized spiral enteroscopy. Indications for spiral enteroscopy: small bowel stricture in 10 patients and obscure GI bleeding in 4 patients. We would like to present a video of our first patient, a 79-year-old gentleman with obscure GI bleeding. Anterograde enteroscopy was done. I do an 18 mm bougie dilatation before the anterograde approach. Nasotracheal endotracheal tube is preferred as the orotracheal hinders spiral rotation. I enter. Now, at this point, I feel a resistance as a spiral segment reaches cricopharynx. With gentle neck extension and pressing the forward pedal, I can advance. I continue to press the forward pedal as the scope traverses the stomach. Minimal water and carbon dioxide usage help the pleating movement. During this rapid advancement, I continue to press the forward pedal with minimal scope movement. To cross sharp bends and angles, standard enteroscopic techniques of torquing and withdrawing the scope is used. In addition, the forward pedal is pressed as we continue to withdraw the scope. Now, I am crossing the bend. Once the forward pedal is pressed, we need to give a few seconds for the pleating action to happen. After a lag, the scope moves forward. In a difficult bend, additionally, the position of the patient can be changed from left lateral to supine. The assistant gives abdominal pressure in all 4 directions to find the right pressure and the right direction to keep the lumen in vision. Reducing the loop by pulling backwards while pressing the forward pedal and abdominal compression helped. When all fails, we may use the back pedal to unpleat a bit before moving forwards. We use fluoroscopy only occasionally, especially when there is no advancement of the enteroscope. This was shot 10 minutes before we entered the cecum. Now you can see the enteroscope entering the cecum through the IC valve. This completes the anterograde examination. Withdrawal of the scope is done by pressing the backward pedal. There is controlled unpleating of the bowel which helps us to target any lesions required. Care is taken that the 80 cm mark is maintained until the tip of the scope exits the pylorus. Again, while reaching the cricopharynx, the neck of the patient is kept extended and gentle spiral rotation is used as the scope exits outside. Results: routes of enteroscopy, anterograde in 5 patients, retrograde in 4, and both anterograde and retrograde in 5 patients. The target lesion was reached or total enteroscopy was achieved in 13 out of 14 patients. Total enteroscopy were 5. Total enteroscopy by the anterograde route alone reaching cecum was in 2. Total enteroscopy with anterograde and retrograde enteroscopy was in 1 patient. Total enteroscopy with retrograde approach and push enteroscopy in the anterograde approach because of difficulty in crossing cricopharynx was in 2 patients. Enteroscopic findings: jejunal and ileal strictures were seen in 7 patients. Jejunal or ileal ulcers were seen in 3 patients. Therapeutic enteroscopy: APC was done in 3 patients. Stricture dilatation was done in 2 patients. The average time taken for anterograde enteroscopy was 61.1 minutes and retrograde enteroscopy was 90 minutes. Adverse events: minor were observed in 3 cricopharyngeal superficial abrasions. Major, 3 had transient hypothermia and 1 had pancreatitis. Novel motorized spiral enteroscopy is a great tool for diagnostic and therapeutic enteroscopy. Pan-enteroscopy is easily achieved with this. Speed and ease add charm to the procedure.